Today, it's my honor and privilege to be here with you to this wonderful occasion. Today is my topic on how to optimize left main PCI. Does it really matters? So let's see if you know the coronary anatomy of the left main. Actually, 1/4 case around body and osteal lesion, and 3/4 are the due to distal left main bifurcation lesion. If you critically evaluate, most of the cases, distal left main bifurcation are really complex PCI cases. If you look at the recommendation, revascular strategy for the left main PCI, we should go for significant left main disease or not. Then you should consider high anatomic complexity of the coronary disease. If it is present, then you should go for suitability of the CABG. If it is CABG, it is still class 1 indication. If it is not suitable for CABG, then we should go for heart team approach for guided directed medical therapy, as well as we to optimize by PCI for the better outcome. If you look, this is also coronary stable artery cases. If it is stable case, significant left main disease, CABG. If it is not left main disease, but not anatomical complexity, but PCI, sometimes it is reasonable when multiple comorbidities there. But question is that whether we should go for complex PCI by PCI or CABG. But that debate for years together, which model is better, PCI or CABG. If you look at the data, composite outcomes in long term or short term, but there is no significant major difference in long term survival maze. But they are the two different modality for the treatment of our patient, left main bifurcation patient, but we have to optimize. Question is that is my heart team shared approach. If it is really complex left main PCI case, then sometimes we should go for heart team approach. Sometimes shared decision making are overrated. All of you know medicine is not a democracy actually. So I find few patients can analyze the data and make an informed decisions. Patient can make the decision mostly on the confidence they get from the surgeon or intervention cardiologist. And also the fear of open chest. And finally, which factor influence the major decision-making process, the experience of the friends and family. If patients, friends, and family are familiar with CABG, they prefer CABG. If they are familiar with PCI, they prefer PCI. But if decision is controversial, tell the patient our heart team isn't agreement on the best treatment modality for you, but it are me and my family member, I would recommend. So you think yourself, if patient is you or your father or your parents, then what should you take the decision? That is the main important issue. If you take the decision for distal left main bifurcation disease, you should treat by PCI, then you have to optimize. If you, this is also in wonderful picture, make the decision influences. After CABG, post-operative day, if you look, that is multiple support you need, but in first post-PCI day, it is patient almost about ready to go home. So that may also influence the decision-making process. But whatever do we take the decision, our main target, how can we provide equivalent reversal with CABG in left main PCI? Of course, we should try to maximum benefit from our patient. So if you look at the registry data from main compare registry data, it is conducted in the Korea, published in 2018 TCT-MD, it is presented. Osteal shape disease, around 20 to 25% cases, but their outcome in terms of PCI is almost similar, but distal left main bifurcation really matter for the outcome. If you go for CABG, it is better outcome. If it is go for PCI, it is not too much better outcome. But I will show you later on 10 years registry data. If you go for IVAS guided PCI, that will give a better result in comparison to anatomy, in comparison to naked eye assessment. If you go for single stent strategy, chance of resistance at the end of the 2 years around 6%. If you go for 2 stent, it is around 25%. It is a quite big number for the resistance rate. So our target, how to optimize bifurcation PCI. Number one, selection of PCI is favorable patient and lesion. Number two, FFR or IFR for selection of the functional significant lesion or not. IVAS guided stent optimization on the top of this guideline directed medical therapy. If you look at our first case, this is osteal left vent significant disease, but if you carefully evaluate it, if you go nitrates, then there is no significant disease, so no need to intervention. But if really significant osteal left vent disease, it is a matter of 5 minutes stenting, you go for stenting, and you go for, if need, you go for optimization by IVAS, then discharge the patient. So in this case, we give GTN, but there is no significant osteal lesion, so we leave it alone. So what is the message from this case? It's only 50% osteal lesion are significant, but all osteal left vent are not truly disease. Second thing, osteal left vent coronary lesions are often eccentric even when they appear concentric. Then if you look at the second case, this is osteal left vent disease critical, and LAD osteal is very critical disease, LCX reasonably very well. And if syntax 24, Euriscus 4, we go for single stent strategy. Straight away we go for single stent, and then we just saw after doing port, we just see that there is a significant or there are 50 to 60% lesion in the osteal LCX. So what should we do? How to optimize our outcome? So single stent or double stent or FFR or IVAS. If you have this sorts of lesion disease, then you have to go for, if you have the functional assessment capability, then you have to go for FFR. FFR done, it is 0.72, it is significant, then we go for provisional stent strategy and optimize the stent by T-stenting, then kissing, then report, and this is the final result. So why port is important? Because port is important to see the proximal stent optimization as well as to side-by-side access capability is give you better comfort. Second thing, this is the ideal strategy to optimization or port technique. You just put the stent balloon just into the carina, not over the carina, not beyond the carina. If you go over the carina, so there is the chance of stent distortion, some source of stent distortion or proximal edge dissection. So if you do for crossover stent strategy from the left vein to LAD, suppose then LCS, sometimes it may be pinch or sometimes it may be disease. There may be side-by-side occlusion. From naked eye, you have some impression, it might be a side-by-side occlusion. So in that situation, you can optimize your procedure by IVAS or FFR. If you go for IVAS, if you look, yes, it is significant disease, MLA less than 4.5, then you should go for second stent strategy. If you go for FFR, if it is significant, then you go for second stent strategy. So during the FFR study, you have to be very careful, because if you see the left vein disease, sometimes left vein disease is not isolated, it also involved in LAD and LCX. You have to run total FFR OR, cause the total distal lesion. Otherwise, you may give false result, false negative result. If you look at this very carefully, first one is okay, second one is okay, third one is okay. Last one is not okay because there is a proximal lesion and distal lesion. If you don't cover the distal lesion, you may not achieve maximum hyperemia. That may gives you a false negative results. So we should be very careful during our FFR study. So why do we need the IVAS for left and bifurcation PCI? There are the two principles. Number one principle, planning for the PCI, either stent strategy, single stent or double stent strategy, reference vessel size, determination of the reference vessel size, and select the bigger stent or bigger balloon in comparison to naked eye. Finally, if you look at the IVAS for stent deployment, after stent deployment, to evaluate stent expansion, stent apposition, or ACE problem, ACE dissection or not. So this is the principle of image-guided complex PCI. What is matter? Image-guided PCI, you should remember PSP philosophy, pre-dilatation, the stent size, and post-dilatation. During pre-dilatation stage, if you advance your IVAS catheter to inspect the lesion, to see the characteristics, to see the lesion characteristics for calcification, plaque burden, and opening of the side branch. If it is not okay, then you can optimize by pre-dilatation as much as you require. You go for NC balloon, you go scoring balloon, if you need for rotablation, if you need for IVL balloon as well. Then you select the stent size. What should you look? We should look for the stent landing zone first, then we go for stent length, then we go for the stent reference size. Then we should stent sizing. After stent sizing, what we should go for the surveillance of the stent outcome, either the stent age is over-responded or under-responded or any age dissection or not. So this should be remember PSP philosophy to use IVAS guided PCI. So why IBUS is preferable? All of you know, all of the studies suggest preferable for a very better outcome. So we should prefer PCI. So if you use IBUS, then sometimes what more need, maybe string number may require more, string length may require more, sometimes oversized standard balloon may require. But our target to achieve, the bigger the better. We should believe the philosophy. If we achieve maximum, minimum stand area, if more than 5, 6, 7, 8, LCX, LED, POC, and left main. So we have to achieve 5, 6, 7, 8 philosophy. So if we go for adequate stand expansion, then outcome is better than under expansion at 2 years follow-up. So if you, this is the left main study, 10 years outcome data from the main compare data, registry data. If you see the IBUS guided PCI much more favorable than angiographic PCI, that is in terms of all cause death, in terms of non-QMI or a stroke. That's why we always prefer IBUS guided PCI as much as possible. So still our guideline is recommended. It is 2A from the from AC, and also AHA, it is 2A. So if you look at this, what is the visual function mismatch and reverse mismatch? That is very important to understand. If you see the visual, this is the first side. Visually, it is look like 80% stenosis, and IBUS MLA around 6.2, but functionally 8.2. It is not significant disease. We should not intervene it. If it is locally right side, if you look, that is the visual estimation around 30%, it is stenosis, but FFR is 0.70. It is significant disease, so we have to treat it. If you go for provisional stenting, then sideburns fine, then you have to intervene accordingly. Why it is the result? If you know the larger microdium, you can achieve more hyperemia, so the result is true. If it is scar tissue, a very small microdium, you don't achieve maximum hyperemia, so you may give false negative result. So if you look at the start case, that is a 50 years male, and there is a critical osteal left vein disease as well as total LAD occlusion and sideburns of L6 critically disease. If you look at this, straight away go for single strategy to save the life, as because it's a critical lesion. Then after doing single strategy, we just run the IBUS, see the opening of the LCX is okay. There is no significant plaque burden is there. So we think we should keep it single stent or double stent. In that particular situation, if you look, there is seems osteal may some disease, but total TB 3 flow is okay, but no hemodynamic, no compromise, no test complaint, no EKG changes. So we left it alone. So we left it alone or double stent strategy, because there is a significant disease. If you look at the Korean registry data, around 72% is negative FFR result. So in that particular situation, we only put single stent strategy. And I should escape. And if you go for single stent strategy, sometimes there is significant plaque shift or carrier shift may give you a false impression there is a significant disease. So what should you do? If it is sideburns disease, then you have to approach like that way. So I have to go for this next case. If you look at this distal left main LAD osteal and L6 disease, what should you do? Go for 1 or 2 stent strategy. If you look at this FFR, there is no significant in LCX, LAD is significant. We go for a straightway crossover technique, and we did it accordingly, but LCX seems to be some disease. Actually, what should we do next? If you look at the IBUS, we achieve around 10 in left main and POC around 9.5 and LAD ostium around 9, distal LAD also 9. So we achieve significant minimal stent area. So we have to satisfy. But when the jailing the LCXR, sometimes it seems to be sideburns occlusion, give you a false impression there is significant disease. But after, if you look, there may be due to carrier shift or due to plaque distribution. But if you go for the functional assessment, it is seems to be anatomically significant disease, but functional assessment, there is no significant disease. So no need of second distant deployment. So what is the result from the functional significant L6 jailing after stent? Only 7% case it is significant. In that particular situation, we on the top of symptoms, on the top of findings, we can consider for second stent strategy. And this is anatomically significant stenosis frequently functionally insignificant. So if you naked eye shows there is significant disease, but clinically not significant, but functional assessment is not adequate, so you don't go for intervention. So why carina shift functionally not significant is because carina shift is mostly very focal and elliptical. Compromise is mostly longitudinal rather than the circumferential. So that is not too much significant in case of a clinical practice. And how to optimize stent overexpansion is the major cause of plaque shift or side branch occlusion. So optimization of the stent technique is very crucial. So my last slide, that is my last slide. Left vein disease is life-saving disease. We must use all the weapons to achieve the best results. Image guided is the key for the optimizing of left vein PCI. IBUS enables safe and effective PCI with larger stent and balloon, resulting in a larger final stent area. Finally, larger minimal stent area after left vein bifurcation PCI was a key predictor of the better clinical outcome. I think I should stop here and thank you very much.